Seizures and status epilepticus are very common diagnoses in the critically ill patient and are associated with significant morbidity and mortality. There is an abundance of research on the utility of anti-seizure medications in this setting, but limited randomized controlled trials to guide the selection of medications in these patients. Time as brain applies to status epilepticus, with delays in treatment corresponding with worsened outcomes. Several recent studies have documented that the treatment of status epilepticus is frequently delayed because of lack of recognition and lack of appropriate first treatment. This delay corresponds to worsened outcome attributable to the delay in treatment rather than the disease process. The purpose of this review is to provide an update on the medications available in the intensivist armamentarium for these purposes. Novel anti-seizure medications. Brivaracetam, BRV, is a racetام-type molecule, which works in a similar manner to levetiracetam and more selective than it. Lacosamide was initially approved by the FDA in 2008 as an adjunctive therapy for partial-onset seizures. In the neurocritical care unit, it has been used for seizure prophylaxis after craniotomy, subarachnoid hemorrhage, SAH, and traumatic brain injury, for the treatment of convulsive and non-convulsive seizures, and as a secondary treatment for status epilepticus. Per the most recent Brain Trauma Foundation guidelines, phenytoin remains the recommendation to decrease the incidence of early post-traumatic seizures, but not for the prevention of late post-traumatic seizures or post-traumatic epilepsy. In all neurocritical care patients with waxing and waning mental status, persistently depressed mental status, or clinically suspected seizures, EEG monitoring is recommended, regardless of cause. This is our recommendation based on the high prevalence, 20%, of seizures, especially non-convulsive seizures, in critically ill patients. Duration of monitoring should be up to 3 days in non-comatose patients and up to 7 days in comatose patients in the absence of seizure detection. There are multiple new and established medications that can be considered in the treatment of these patients once status epilepticus has become refractory, and it is unclear what order these medications should be added, given lack of clinical trial data comparing efficacy with sufficient sample size.